Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
And thank you, Deborah. It's a pleasure to be here with you all. And thank you to the audience for being here. This session, Driving Healthcare Value, Examining Patient Safety, Prices, and Scarcity, was organized by Monique, Cote. And today's moderator will be Natalie Helbig. And so let me bring Natalie on the stage and take this down so we can. There we go. Hi, Natalie.
Hi, Charles. How are you? Hi, everybody.
Nice to see you. You have this stage. Thank you.
Thank you. Well, welcome, everybody, to the Driving Healthcare Value and Examining Patient Safety, Prices, and Scarcity. Today, we have 3 really good presentations, and I want to introduce our first presenter, Shannon Garrison. She'll be talking about measuring healthcare safety in outpatient settings. So please give the floor over to Shannon, and we'll have an opportunity for questions at the end, but please put your questions in the chat as we move along.
Hi, everyone. I'm Shannon Garrison, and I really want to talk to you a little bit today about outcome and safety measures, but in the outpatient setting. While there are many quality and safety measures for inpatient stays, there are much fewer for outpatient procedures, and even less that are objective outcome measures. But there is an increasing need for them. The landscape of surgical care has significantly transformed. Today, ambulatory procedures surpass inpatient surgeries in volume, and 1 in 48 patients undergoing elective procedures in a hospital outpatient department experience a preventable complication within 30 days. Data fragmentation across care settings further complicates the picture. Without a standardized method to track patients post-procedural, it's difficult to connect post-acute outcomes back to the original procedure event. This lack of visibility makes it challenging to identify complications, improve care processes, and assess patient risks accurately. In addition, care variation across providers remains a persistent issue, contributing to inconsistent outcomes and inefficiencies across the system. Together, these challenges represent an urgent opportunity for improvement. Improving visibility into outpatient procedure outcomes is essential to advancing patient safety, promoting accountability, and delivering higher value care. When we think about tracking patient safety and complications, the inpatient setting provides a clear and structured framework. On the left side of this graphic, we see an inpatient admission. Everything that happens to a patient during their hospital stay is captured within the electronic health record. But ambulatory or outpatient care presents a very different challenge. Shifting to the right side of this graphic, we see what happens when a patient undergoes an elective procedure in an outpatient setting. Whether it's in a hospital outpatient department, an ambulatory surgery center, or a clinic, the key difference is that the patient is discharged from home immediately after the procedure. From that point forward, any complications they experience may present across multiple care settings over the next 30 days. They could return to the same hospital, visit an emergency department at a different hospital, follow up with their primary care provider, or even receive care at a separate specialty clinic. The ability to track a patient across these encounters is incredibly powerful, but also incredibly complex. Unlike inpatient care, where we can evaluate everything within a single hospital stay, outpatient settings require us to piece together fragmented data from different providers and care locations. Without a standardized way to track these outcomes, we miss critical insights into patient safety and procedure quality in the outpatient space. So why does that matter? The ability to track post-procedural complications in outpatient settings is not just about the data. It directly impacts patient safety, quality improvement, and cost containment. Tracking complications and being able to compare them on a risk-adjusted basis allows improvement efforts to be targeted at the procedures and providers that have the most opportunity. Efforts to make improvements will reduce impact to patients and save cost of care by preventing adverse events from ever even occurring. Solventum has been trying to solve that problem by introducing ambulatory, potentially preventable complications. They're specifically designed to address gaps in data and tracking of safety and quality by identifying complications that arise post-elective procedures due to care and treatment processes rather than the natural progression of illness. In essence, these are complications potentially preventable through improved clinical practices, surgical techniques, or post-procedural management. At the top of the slide is a patient example, a patient undergoing elective knee surgery with same-day discharge. Our analyses monitors the patient for 30 days after the surgery. On day 8, the patient returns and is admitted with a complication. In this instance, a pulmonary embolism. This admission encounter is flagged as potentially preventable because it is directly related to the knee surgery, or plausibly so. As demonstrated in our timeline, we continue monitoring the patient for the full 30 days, providing a comprehensive information regarding encounters back to end users for informational purposes. By day 30, monitoring concludes, capturing a detailed post-procedural picture. This capability is underpinned by 4 core value components that render ambulatory potentially preventable complications both clinically meaningful and operationally actionable. Post-procedure tracking links all follow-up encounters back to the original procedure, creating a unified view of outcomes. Preventable complication detection isolates issues that could have been avoided with improved care practices. Risk-adjusted benchmarks ensure fair comparisons across populations and procedures. And observed versus expected insights identify where care variation is occurring, enabling organizations to target improvements effectively. This solution brings structure, transparency, and clinical relevance to the outpatient space, addressing a long-standing need by surfacing complications like hospital admissions and emergency department visits that are clinically related to the initial procedure. When viewing complications, we can use observed versus risk-adjusted expecteds to guide performance improvement strategies. This approach enables a normalized apples-to-apples comparison, both within and across provider network, by accounting for key differences in their mix of patients and procedure complexity. Using this kind of structured risk-adjusted output allows objective comparisons of performance across providers and highlights opportunity for improvement. We can see that then this variation allows us to see where some providers may be performing worse than the network average. Provider A, for example, not based on their volume of procedures, but truly based on the complexity of those procedures that are occurring. And they could benefit from some opportunities and improvements. Whereas when we look to, we see the variation also with the best in the network as we look at provider E, and we can look to them for best practices. When we're improving outcomes, we're reducing harm. using those ambulatory potentially preventable complications is one way to try and measure so that we can understand and act upon those outcome measures that are causing poor safety. Thank you. I think you're on mute, Natalie.
I am. Thank you. It was very interesting. Do we have any, now there's an opportunity for us to open up any questions we have from the audience for Shannon. So please let us know any questions you have for her. While we're waiting for folks to share their thoughts, Shannon, I had a question for you. What are common data quality issues that need to be addressed in order for data to be a good match for this type of analysis?
It's a great question. So one of the things that we try and do with actually all of our methodologies, and so we followed through with this as well, we try and use data that's commonly found in claims. So it doesn't necessarily have to be from a claim, but it's data that's already being collected because it doesn't put extra burden on a provider. However, if you're a provider and you're trying to make changes and correct safety, you somehow need to get your hands on that longitudinal data. So be it that's happening outside of your walls. So a lot of times programs through maybe a payer can help collect all that data, or using an APCD or other ways to, but really it's about getting access to that data. That's the biggest leap, but it is data that's being collected. So we try and mitigate it that way. And then overlaying the clinical methodologies on top of that to make sure that it's not just data for the sake of data and saying that all these things have occurred. We want to make sure that it's clinically plausible, that it actually was related to that service, so that it's not giving us false responses and false outcome.
Yeah. I think that's the picture in the beginning of the presentation where you showed how a person can go to all those different locations and encounters. That was really, it sort of hit home of what the data question, the data difficulties might be, but also the opportunities, like you mentioned. I wanted to mention that we have a poll going on right now. And if you guys in the audience want to provide some input, you can see where the idea is: when measuring patient safety, which type of adverse event would you most like to track and attribute in the outpatient setting? Right now, the audience is saying diagnostic errors, misinterpretation of a test or symptom. Shannon, how does your ambulatory surgery sort of software sort of work into that kind of question?
So what we try and do is we really look at that actual over expected. We created benchmarks to look at for comparison, and then we can even localize those benchmarks depending on the size of the data set. But the point being that then what you're looking into for events are truly the events where there's some opportunity. So you can actually start to look at, what's happening underneath each of these events and start to dig in. Because if you try and go into those like diagnostic errors and looking at the DX codes compared to what truly happened and what was actually occurred with that person, and you go through that with all of your events and every surgery, you're just going to get bogged down with too much data. So where we're trying to get at is really that spot in the variation where you can take action, so that then you can dig pretty deep into those cases when you've narrowed it down to the spot that has the opportunity.
Great. We have a question from our audience. How did you set your expected benchmarks?
Great question. So we started our benchmarks using the Medicare 5% data set, and then we hone them in using beta testing. So with some of our beta customers, so with Medicaid and commercial plans, as well as several hospital plans.
Fantastic. I noticed in the polling, we started to get some uptick in medication errors. And I noticed in your picture, there were no pharmacy claims in there potentially. Was that on purpose, I guess, or
It is purposeful, because what we're measuring is that you ended up back in, say, the emergency department. So they would be the ones making that call and saying, well, this is what you were prescribed and you now had an allergic event because of it. So it's not that we won't catch that
Gotcha.
It was a medication error, and that would be in the detail, but it's more that that's not what happened to you. That's not who's surfacing it.
Excellent. All right. Do we have any other audience questions? If not, I think we can start our next presentation. So our next presenter is Joseph Dieleman from University of Washington. His presentation is Assessing Healthcare Spending and Utilization Across U.S. Counties and the Urban-Rural Divide. Joe?
Hi, my name is Joe Dieleman. I'm a professor at the University of Washington and work at the Institute for Health Metrics and Evaluation, also at the University of Washington. And it's really a joy to be able to present this work today. I want to thank the conference organizers, Norm and Charles in particular, for all the work that went into organizing each of these sessions. Also want to thank my co-authors, many of whom have put in many hours into this project. And so thanks to them as well. Today, I'm going to present on healthcare spending in the United States and particularly look at variation in healthcare spending across counties in the US with a special attention to the urban-rural divide. So I have three parts to my short presentation. The first is I'll introduce what we call the Disease Expenditure Project. Then I'll talk about cross-county spending variation, and I'll end with providing information that you could access more about the papers and this research. So starting with an introduction to the project. The Disease Expenditure Project's main goal is to simply understand where healthcare spending is coming from, where the resources are coming from, and where the resources are going. And so to do that, we start with essentially the $4 trillion that's spent on healthcare in the United States and disaggregate that into pretty granular buckets. And at the end of the day, we make about 10 billion estimates for this project. The reason we make so many estimates is because all of our estimates are at the US county level. There's 3,110 US counties. We also stratify healthcare spending by payer, and we have 4 payer categories: Medicare, Medicaid, private insurance, and out-of-pocket spending. And we're doing our best to capture all healthcare spending. So we look at all major types of care: inpatient, outpatient, nursing facility, pharma, and so on. And we also make stratifications by age, sex, and health condition to really understand where the resources are going and what they're being used to treat. Our current set of estimates only extend to 2019, but we're in the process of updating that through 2022. We're just getting access to the newest data that should allow those newer estimates. And one last kind of interesting thing we do is we also make all of our spending estimates by race and ethnicity. So we have 5 categories that we use to look at healthcare utilization and spending disparities in this country. But again, the key point is simply to understand healthcare spending and also utilization. So how many visits, how many admissions, how many prescriptions are happening in each place for each disease. So in order to do a project like this that makes 10 billion estimates, we start with a lot of data. We use over 40 billion insurance claims coming from Medicare, Medicaid, and private insurance. For the uninsured population, we use hospital discharge data as well as survey data. And ultimately, this is a big data exercise in pulling together all these different data sources to make our spending and utilization estimates. One of the tables that we produce is this one. We published this in February. It's a look at healthcare spending growth over time, disaggregated by type of care in the top yellow and by payer in the bottom green. And one of the cool things that we can do is disaggregate spending across these categories, but also look at the growth rates and the growth rates that are adjusted for inflation and age. We know that the population is aging in the US, and Medicare disproportionately accounts for the oldest part of the population. And so when you make those adjustments, you see really important differences in where healthcare spending is going. We also look at the health conditions that are driving most of the healthcare spending in the United States. This is the top 20 health conditions. We see diabetes, other musculoskeletal disorders, and oral disorders are all categories that really lead to the most spending, all with at least about $1 billion of annual spending. And the kind of important thing to recognize is this table, which is at the national level for 2019, can be made for each state and county in the United States. And so if you're interested in what's driving healthcare spending or disproportionately driving spending in a specific place, you can see what stands out as the key drivers of healthcare resources. We know in the US that as people age, they spend more on health because of the way the population age structure is set up. We spend more on the 65 to 69-year-old population than any other age group. That's kind of a bulge of spending on essentially the baby boomers as they move towards retirement. But when we look in per capita terms, like you see on the right, we spend more per person each year of their life. And so we spend the most on the 85-plus-year-old category. So this is the map that actually took quite a few years to produce because it required increasing the amount of data we use as inputs. But it allows us to see healthcare spending, age and sex standardized across the 3,110 US counties. The darker purples here are healthcare spending that's right around $10,000 per capita, whereas the whitest colors are right around $4,000 per capita spending. And I think it's really important to recognize that while I think most of us knew there is tremendous variation in healthcare spending across US states, we see that within states, there's pretty much just as much variation. And you see in pretty much every one of the states, some of the whitest colors, the counties that have right around $4,000 spending per capita. And sometimes right next door to it, you see counties with substantially more resources spent per capita. And again, this is adjusted for age and sex. So we're in many ways comparing apples to apples across these different counties. So this essentially suggests there's a huge amount of variation in spending across counties in the US, which really led to another project where we wanted to pose the question of why is there so much variation? Can we explain some of this variation? So we used what we call a Shapley decomposition to look at the variation and essentially decompose that variation into 4 key factors. So the green on this figure highlights the population age of a specific place. We know older places spend more. The orange is the disease prevalence. We know sicker populations spend more. But the blue and the pink turned out to be the really big drivers of healthcare spending variation. The blue is service utilization. And so we see that over 60% of healthcare spending variation across counties in 2019 could be explained simply by differences in the way people utilize services. So if people are going to outpatient versus inpatient, if they're going a couple times a year versus not at all, those are the really big differences that led to some counties spending 3 or 4 times as much as other counties. And of course, service price and intensity also was a major factor. That's the pink bars, and about 20% of the variation was explained to that. But really, the blue is the important part. That's service utilization, and that's what really drove a lot of the variation. This is a figure that highlights why each of these states spend a different amount than the national average. And so the vertical line here is the per capita national average. And every time the dot is to the left of that, like you see in Utah, that is the state spending less on healthcare per capita for that type of care in 2019. And anytime the dot is to the right, it's because the state is spending more in per capita terms for that type of care. And then the colors highlight why states are spending more or less than the national average. So in the case of Utah, you see these big green bars, which is associated with the population age fractions. So Utah happens to be the youngest state in the country. It also is one of the states that spends the least. And you can see that that's a major part of the low spending in Utah. But you also see the orange pushing to the left. Utah is a very healthy state, and disease prevalence tends to be lower in Utah. And that's another reason for less spending in Utah. For Massachusetts, we see there's a huge amount of spending, and a lot of that has to do with higher utilization. So it begs the question, what does this look like when we're thinking about rural and urban breakdown in the US, especially if utilization is really a major component to the differences in spending levels? Here we see that both rural and urban counties tend to have high spending in some places, and especially rural counties tend to have some counties with very low spending. Across age and payers, we see that urban areas pretty much always spend more in per capita terms than rural areas. Ultimately, rural areas in per capita terms spend about 90% as much on average as urban areas. And that's true for most payers and age groups. The only difference is where Medicaid spending for the oldest population is the one place where we see rural counties spending more than urban counties. So what's our conclusions? We see there's huge variation in spending across US counties. The majority of that variation can be explained by utilization. And we see that rural America, which spends substantially less than urban America, despite being older and less healthy, is spending less for all payers and most age groups. If you want more information about this project and you're interested in peer-reviewed papers, we got plenty of those. These are a few that were all published this year, which you can find online, all publicly available. Really cool is that our website is accessible and allows you to explore all of the estimates, all 10 billion estimates on your own. So if you're interested in a specific state or county, you can zoom in and see spending or utilization rates, age and sex adjusted or not. Again, lots of information online. We also have state briefings, and here's the website that you can check out if you're interested in any specific state. The state briefings provide comparisons to other states, as well as information about what health conditions are driving spending. And please reach out to me if you have additional questions. Always happy to try to answer questions and make the data more accessible to policymakers and different users of the data. So thanks so much.
Thank you, Joe. That was great. I really appreciated the succinct way you walked through each of the elements of your project and really threaded through how it all came together. So thank you. We actually, we're going to turn it over to audience questions. We have one already from Sarah Crawford. Joe, how do you decide what to include in each health condition? Is it like med and pharmacy spending for a person with evidence of that condition, or events that specify the condition, are drugs specifically for that condition, etc.? If a person has more than one condition, is their full medical pharmacy expenses counted under both or each condition?
Great, thanks. Thanks, Natalie, and thanks, Sarah. Great question. So this is, in many ways, it's a many-year project, and so answering your question is something we worked on for many years. Essentially, we have, as I mentioned in the presentation, the main data source is insurance claims. And so we highlight using ICD-9 or ICD-10 diagnoses, the kind of primary diagnosis for the visit or the admission. And then we also, through regression analysis, do adjustments for comorbidities. And so what we're really trying to measure is the spending attributable to a health condition. And so let's just say, for example, if someone has two health conditions and they go to the doctor for their visit, they have a primary diagnosis, but the secondary diagnosis, say the primary was diabetes, the secondary is heart disease, that heart disease is going to drive up the spending on the diabetes. And so we want to reallocate some of the diabetes spending to heart disease. And so we use this regression analysis. We run the regression over 10,000 times to essentially assess all the different combinations of what's driving up healthcare spending. So that's for most types of care. For pharmaceuticals, we have a different process. We essentially use data on what drugs are used for, both on and off label, and then combine that with when the prescription was given and why the person had an inpatient or outpatient visit. And then we use a machine learning algorithm to kind of connect the two. So the project, as I kind of mentioned, it's taken many years. It also is very data science oriented. It's about essentially coming up with these estimates with as much data as we can use.
Very good. Thank you. We have another question in the chat, and it sort of goes along with the concept of what Charles had put in there, which is anecdotally, the rural farmers I know just don't go to the doctor even when they're sick. Other than availability of services, is rural attitude a factor?
So yes is the answer, in the sense that I think attitude and behavior and preferences matters for driving spending and utilization. What we're able to capture in our study is the spending and the utilization. We do some attribution to kind of key drivers like disease epidemiology and age. But beyond that, we haven't really kind of assigned or attributed those differences to key things. But I think there's a lot that's going on that drives those differences in utilization. Some of it is physical access, some of it is income and insurance coverage, and some of it is just simple preferences and behaviors. So a lot going on that drives the utilization. But to reiterate what I said in the presentation, it is utilization. We know that that's really driving that spatial variation. But what drives the utilization variation is, I think, another research project, one we haven't done yet.
That's great. Similarly, the impact of this kind of analysis and sort of putting a big picture out there, how have these estimates that you've worked through, how have these estimates been used by policymakers?
Yeah, thanks. So I tend to break, and this is an overgeneralization, so apologies in advance, but I tend to break policymakers' motives into two distinct groups. So there's people that are really interested in cost containment. And I think our analysis can be useful for cost containment because it allows users, stakeholders, policymakers to identify where spending is going up the most, and also where there's spending anomalies. Why does one state spend a lot more on home health care than another state? Or why is spending on diabetes per prevalent case substantially different in one state versus the other? So it allows those kind of pinpoint kind of moments where you can understand either changes over time or just in level space why more spending is happening. So I think it can be good for cost containment. It also, that's kind of second interest that I think of is folks kind of interested in access issues and disparities. And that's also what I think our study does a really good job of. I didn't highlight any of the race ethnicity findings, but we have all of the estimates broken into 5 race ethnicity groups. I think our study is really good at saying, here is a location, here is a population that is, we know, maybe more sick but doesn't have the chance to access facilities or isn't choosing to. So again, in simple terms, we find that there's 2 users. There's people interested in cost containment, and there's interest from people really identifying where there's facility gaps and use gaps.
All right. I know that pricing and cost are always a hot topic. So we've got 2 more questions.
Great.
One from Alyssa. I believe one of your drivers was price and service intensity. How is service intensity defined? And in particular, how does it differ from service utilization?
Yeah, great question. So, and thanks for getting into the kind of the nitty gritty of it. We don't differentiate price and intensity of care, mostly because we haven't been able to. What that category is defined as is it's spending per visit if it's an outpatient visit, or spending per admission if it's an inpatient visit. And remember, it's disease specific and age and sex specific and location specific. But the idea is we don't in our study break down the different services that took place during an admission or and a stay or an outpatient visit, but we have the total price for the visit. And so when we see changes over time, that could be because prices are going up. It could also be because we're using more MRIs instead of X-rays. And so there's an intensity component and a price component that at this point we're just not able to differentiate, unfortunately. We see the change over time. We see the differences between 2 places. I think we hope to eventually go a little bit further, but right now that's kind of where we're stuck.
Okay, I think we have time for one more question. Sylvia. Sylvia's confused. When you examine between state variation in total healthcare spending, it is still not clear how you are measuring to what extent elevated spending reflects condition-specific price differentials, such as higher negotiated reimbursement rates, rather than differences in utilization, disease prevalence, acuity, or service intensity.
Thanks, Sylvia. So let me try to explain it again. Essentially, we, and I wish I'm a professor and a teacher at heart, but there's 4 things that multiply together to create spending. You have the age group, and so the fraction of the population in that category. You have the disease prevalence, and then for us, utilization is number of visits per prevalent case, or number of admissions per prevalent case. And then the last part is the spending per admission. And the product of those four terms gives you total spending. And if I was able to write it on the whiteboard, it'd be a little bit clearer. But the idea is that we can see how each one of those drivers changes. And so when I say utilization is driving the spatial variation we see in 2019, that means that changes in the number of visits per prevalent case for a disease is very different in one place versus another place. And again, this is done by type of care. So it means that in some places, we believe that our estimates show that there's more maybe ED visits for diabetes. And in another place, maybe there's more outpatient visits. And in another place, there's just not a lot of visits per diabetic person living with diabetes. So that kind of level, that variation that we see in utilization is really what drives the big differences in spend.
Thank you very much. I think that was a good segue into our next presenter. Thank you, Joe. We'll bring you back on a little bit later. Our next presentation is John Kasey from Milliman. He's presenting on using data to identify areas of healthcare scarcity. John?
Hello, my name is John Kasey. I'm a senior healthcare management consultant with Milliman. I have a background in health plan operations and strategy work. And in particular, I spend a lot of time working on access to care measures and working on identifying ways to improve access to care for populations. I'm really looking forward to chatting with you today about different ways that we have found to combine different data sources that may already be existing in your market or in your plan or in your organization to try to provide a more comprehensive view of where healthcare needs are most acute. All right, so we'll go ahead and get started here. So we're going to, in talking about this, we're going to run through an example of a public sector client that we worked with, which was the state of South Carolina's Medicaid program. The state of South Carolina came to us and they were interested in understanding how to best prioritize the distribution of graduate medical education funding. So graduate medical education funding is a unique lever for state Medicaid programs where they can fund medical education school positions usually with the intention of trying to boost access to care within their state by doing that. They wanted to understand where should they put that money? Where should they prioritize those positions from a geographic perspective and in what clinical specialties? So the current way that we measure access and adequacy and look for gaps is primarily by looking at geographic access and adequacy. And this is driving time and distance. So what is the distance and the time between 2 points, one point being a member's location or a patient's location, the other one being a provider location, and then also provider counts and ratios of number of providers to number of members. Now these are good, except they don't take into account, these types of measures don't take into account how personal access needs are. So everybody has a different need for access. Some people need their access near their school, some people need it near their work, some people want it near their home. Some people want it in the evening, some people want it in the morning. And so we wanted to try to take a look at what is the true demand for access. And we had a unique opportunity here because we have access to multiple data sources with the state of South Carolina. We did end up looking at using, so the South Carolina Medicaid already had access standards. They were not at the time, they are now, they were not at the time very specific and they didn't vary by geography type. And so we recommended that we move forward with what are called QHP standards or qualified health plan standards. These are the types of access standards that health plans have to meet if they want to offer insurance products on the exchange or the marketplace for Affordable Care Act plans. The key thing about these standards is they vary by specialty and they vary by geography type. And what I mean by geography type is how densely populated is a county. So is it a rural county or is it a metro county or is it a county with extreme access considerations, CEAC? So we applied these standards in our so that we were able to get more granular on the specialties we were looking at, as well as provide a more detailed look at the different geographies in the state. Now, I spoke about the kind of unique and opportunity we had with different data sets that were available to us here for this analysis. So one, we use South Carolina provider and member files. Now, this is pretty typical for us when we start to look at access and adequacy work. This allows us to measure the distance. If we know those locations, we can measure the distance and time between 2 points. We also looked at CMS taxonomy and specializations, as well as use some internal crosswalks to take those provider files that we got and clean them up and assign the right specialties to them so that we could do an analysis that was clean across all the different domains. And then we looked at, key to this was South Carolina claims data. This allowed us to better define what specialties are providers truly offering, identify what we call ghost providers, or providers that are maybe listed on a roster and available out there in the market theoretically, but they aren't accepting new patients or they're not actually providing services. And so we removed those from this analysis because we didn't see them as valid access points. And then it also allowed us to look at member utilization. So combining those three types of data, we were able to create what we called an area of need score. So we looked at geographic access and adequacy, provider to member ratios, and then utilization in that area. And by looking at all those pieces and weighting them, we were able to provide a measure of low, medium, or high need for every specialty and for every county in the state. The examples we have here are if we had high network adequacy, so good network adequacy, high provider to member ratio, so a lot of providers to members, and high utilization, we would have a low area of need. We wouldn't need a lot more providers. And then the inverse in scenario 2 is true as well. What this allowed us to do is to create a report, an analysis and a report. Here we have an example from that report of the results for neurology. And so you can see in the upper left-hand corner, this small map, this is the state of South Carolina. And then all the little shaded areas are the counties in South Carolina. The darker blue shading represents where there is more of the Medicaid population. The lighter shading is there's less. You can then see the little red dots represent the providers that are in network there currently. For the most part, those providers are centered around where the most members are, but not everywhere. We also see utilization per thousand, providers per 10,000 members, providers per 10,000 members, and the network adequacy pass-fail. So you can see every county here in South Carolina passes the current regulated network access and adequacy standards from a geographic perspective. If they didn't, that county would be colored gray. And then that allows us to create a heat map of the level of need by area, by county. So the darker red areas have a higher level of need. The lighter have lower level of need. And then in this case, we also split this up by regions because that is how the state like to think about their program. So in this case, if you look to the right-hand side of the screen, we have neurology access and adequacy. And at every county, we have every county in the state listed here. We list the number of unique providers, the providers per 10,000. And then we also provide an additional column here using some proprietary data that Milliman has, where we identify other providers in the area that maybe they aren't accepting Medicaid patients, but they operate in other lines of business. So for instance, in Charleston here, you can see there's 35 additional providers that we identified that are maybe practicing in commercial or Medicare that aren't currently taking Medicaid patients. And so those are opportunities to just go contract to increase capacity. We then get the actual utilization per thousand, the time and distance scores, percentages, whether or not you passed or failed, and those time and distance scores, all these are passes. And then the summation of the utilization per thousand rank. Again, all of these are ranked relative to all the other counties in the state. That's the rank. That's what the ranking is against. The providers per 10,000 rank, the access rank, and then the total area of need rank, which is a roll-up of all of the rankings that came before it. We also have the regional ranking down at the bottom. So the major takeaways from this work were that there is high geographic access across the state, and that those geographic access measures are important, but they're kind of a baseline. That there is further data that is needed to understand where care is really stretched thin. We also found there was a higher than we expected level of low or no utilization providers. So these are those ghost providers. Approximately 40% of the providers we looked at were considered ghost providers because they had no utilization in the claims data within the previous 12 months. And then finally, we found quite a few opportunities to just add additional providers through contracting, which would be a smaller or maybe a less intensive step than having to fund a GME position in a school. And then so we took all this information and we ranked all the specialties and the regions, the regional demand within the state. And what it laid out is kind of what's on the right-hand side of the slide here, which is OBGYN had the highest level of need, dermatology the second, internal medicine third, pediatrics fourth, and then family medicine fifth, as far as rankings of level of need. And then you have the regions on the right. The primary takeaway here is that, we're really excited about the idea that when you can get a more granular view if you apply multiple data sources, particularly claims data, and if you're able to match that up with your provider files and your member files. And so in the case where those things are all available, we'd advocate for taking a deeper view when looking at access and adequacy than the traditional geographic access and adequacy. Thank you all for your time, and I look forward to discussing this with you further.
Thank you so much, John. That was great. I think it ties in nicely to Joe's presentation about utilization and how access to care can also probably drive a difference in utilization in some of those areas. We have several questions, a couple housekeeping questions for you. Mark asked, when I hear GME funded positions, I assume residency slots. Is that what you focused on?
Yes, that's correct.
Okay.
That is essentially what we're talking about in the state.
Okay. And Anya had a question. Can you say what the darkest lines are again?
Yeah, on those little maps, and I do apologize they came out so small, but those lines were essentially dividing the regions in the state. So those darkest lines, that the state of South Carolina likes to think about their program in terms of regions, and so that was dividing their regions up.
Okay. If the audience has additional questions, please add them to the chat. I had a question for you, John. In the beginning of your presentation, you talked about people's preferences for access near a school or things. How did that feed into the analysis, or is that another next step in figuring out how to sort of work that into policy strategies?
Yeah, so it's a good question. The only data that we have for this project on these types of preferences is to look at what is their actual utilization. Where do they actually go to get care?
Gotcha.
So in a way, we're taking those preferences into account, but where supply is limited, there may not be options. And so
Right.
It may have nothing to, that correlation between their utilization and the preference actually may widen, frankly.
Okay.
They
Yeah.
may just be getting care where they can, when they can, as opposed to what they really want.
You mentioned a couple of different kinds of data that you needed to do the analysis. In your experience, how can states or others set themselves up for doing this kind of analysis easier?
Yeah. One of the biggest barriers to us even completing this analysis, and we do a lot of this kind of work, was cleaning up the data and matching up the member file, provider file, and then also the claims data. And those things theoretically shouldn't be that different. There should be ways to join those together. But there's a lot of noise in that data. That data isn't all submitted cleanly. And so one of the best things that I think an organization or a state can do, a regulator can do to set themselves up well, is to request common fields between those files when you're getting that data. And I think there's been steps in the right direction there with regulation and transparency rules over the past few years. But there is still quite a bit of dirtiness in that information to try to match it all up.
Mm-hmm. Absolutely. I agree. We deal with it every day.
Yeah.
Mark has a follow-up question. Mark says, this would be an interesting approach for rural hospital bypass. I'm not as familiar with rural hospital bypass, but Mark, John?
I'm not either.
Okay.
So Mark, if you wanted to share a little bit more there, but we do think that there's potential in this approach to try to take a more informed view of what, especially in rural counties, what's actually needed. Where is there really demand there? You know, the previous presentation that Joe did, it was interesting. He showed much heavier utilization in urban centers than in rural centers, and that makes sense, and that actually tracks with the analysis that we have here as well. So if that's a component of rural hospital bypass, I'd be interested to learn more.
Great. All right, we have about 10 minutes left. I think it would be a great time to bring all our presenters back onto the stage, and we can have a sort of conversation amongst you all, because I think one of the things, you know, and our audience can continue to ask questions. You know, as I was listening to all of your presentations, you know, we started with Shannon, who was sort of presenting a new way forward on how to look at sort of patient safety and better outcomes in ambulatory surgery, and how to track those patients. And so that was exciting, because, you know, you're pushing the bounds of you know, methodologies and such. And then we moved to Joe, who was looking at spending in healthcare and utilization, and that sort of dovetailed, like I just mentioned, into John's presentation about, you know, how we look at people's preferences for, you know, utilization, and how they utilize things, and how that impacts their care. So Mark, before we get to questions, Mark did follow up, so I want to give Mark some time here. He said, in rural areas, people bypass their local hospital to go to an urban hospital. It is part preference and part access. So I think that actually applies to everybody here. So John, how would you sort of answer Mark's question there? Basically.
Yeah, I think it does apply. It'd be interesting to get more granular from county to county and actually track some of the member movement there, which we could do theoretically if we have the claims data and we know where they're located to start. So we could see what their actual, you know, if we could take a smaller view as opposed to looking at the whole state. I think that'd be a really cool, actually, analysis to do.
And Joe, what do you think about the urban-rural divide in that kind of context of people bypassing?
Yeah. So what we actually track is when I show a county map, it's based on where people live. And so we do have in the claims data where they're seeking care as well. But what we've really focused on is people's residence. So we would essentially not be, our data set wouldn't be perfect for tracking the rural hospital bypass.
Okay. And Shannon, I'm curious, does the 30-day care have anything to do with people's access to different, you know, places to go when they have a complication?
Yeah, definitely. So some of it's around follow-up. So it may be that they end up back at an emergency department, or even unfortunately end up as an inpatient because they didn't have any place to go to see their surgeon. I mean, maybe their surgeon, they'd have to go back to an urban setting to see their surgeon if that specialty wasn't offered closer to where they are and there's no way to follow up. So we do track when they go back to just a regular office visit as well, just so that you can see what is working and you can start to look at some of those access issues that fall into that also. And see where they're going, because we look at the individual services too. Some are just not offered in those rural settings.
Interesting. We have another question from Sarah. I wonder also if you've looked at, and it doesn't say who it's directed to, so we'll just say, I wonder also if you've looked at demographics of the current providers to see if people are seeking providers of their same demographic at times, or if certain groups of doctors might be getting close to retirement age and will need replacements. So I think that's maybe John.
Yeah, I love this topic. We definitely do look at this information. So we work with clients pretty frequently to help them understand. We call it provider centrality. It's just a term that we use, but essentially the essentialness, and then we kind of create a rating based on their graduate age, actually, and for some age and retirement age from that, about what's the potential turnover. You get predictive about what's the turnover. So we like to help our clients. We typically talk about, well, when do you need to start boosting access ahead of time, as opposed to it kind of creeping up on you and then you're being surprised by it. So that definitely happens. And then we do and have looked at demographics and kind of whether or not those things match up with populations and physicians and networks before. However, it's actually really hard. It's not hard to do that analysis. It's hard to make those things match up because there's such a limited supply of providers in most cases. So we're usually just looking for a provider, not one that is actually fitting all of the different, checking all the boxes that everybody wants for their personal provider and their personal needs.
Yeah, like I said, it's interesting when you triangulate all your areas, because I think about, like Shannon, are you in your methodology? I don't think I saw it. You're checking outcomes, but what about the cost of those associated outcomes and how it drives up the cost of care? Is that factored in there anywhere, or?
Yeah, so the events that we look at, these poor outcomes, they're essentially never events in this case. So not the back to the doctor and tracking that, but ending up in the emergency department, ending up as an inpatient. Those are the events that shouldn't have occurred in the first place. So it becomes a lot easier, right, to track costs. Where it becomes harder to track costs is what Joe and John have been doing and really trying to say, well, what exactly is occurring, and coming up with that and the severity of illness and the acuity of what was occurring. So we do have other methodologies that we've overlaid to look at some of that with our customers and really try and analyze truly what's happening when they're an inpatient, what's happening when they're an outpatient, like DRGs, for example, and trying to say, well, what would be the cost if you were to even it out, and look across the different providers.
It seems like all of you have a core sort of, there's a core factor here, which is providers, right? They've got to do the right thing and they've got to be in the right area, and they so that's kind of interesting. So we have another question from Kendra. John, do you have any documentation of your methodology you can share so others can use the same approach to identify areas of healthcare scarcity?
I do, and I don't know exactly how we'll share that out, but there's a publicly available paper, so I'll get the link out to you all somehow. That's been posted out there for this work that I talked about. So that is out there, yes.
Okay. And I think the same can be said for our other presenters. Shannon, I think if you have methodologies or support document for yours, and Joe, I think Charles put your main website in the chat for folks. We only have a couple minutes left. We have another question. John, have you explored, from Sarah, have you explored to what extent providers leave after residency to practice in other areas and incentives to stay long-term in the place of residency?
We have not done that analysis. I can imagine the different data elements that we need to do it, but no, we haven't done that piece related to this work.
All right, we got another one from Melissa. Joe, how large is your team that builds the 10 billion estimates? Did you run into any technological issues to process the data and produce results of that magnitude? That's a lot.
Yeah, as I kind of hinted before, it is more data science than anything else. The team right now is myself, and I run a couple different teams, so I'm kind of partially on it, but then we have 6 different data analysts with kind of different specialties, and to be super candid, we've been doing this project. I just counted; it's been 12 years. We've added on as we go. At the end of this calendar year, we'll have a couple new ways that we can look at the data, splitting Medicare Advantage from traditional Medicare. Breaking out primary care is something a lot of people have asked about. We're going to be able to do that by race and ethnicity and state. And then we'll have estimates through 2022. So we're kind of always iterating, always adding on, always adding more data. That's what's prevented us from having more recent estimates, but going through 2022 is kind of our next big step.
Fantastic. And Shannon, just to double check, the product for ambulatory surgery, that's available, or is that still in development?
It's available. Yeah, we've been out for about a year. And US News and World Report is actually using it as one of their factors to judge providers.
Fantastic. All right, I think we are at time, and I want to thank each of our presenters, John, Joe, and Shannon. I think hopefully the audience got a great glimpse into the many factions of how to look at patient safety, prices, and scarcity. So thank you again, and enjoy the rest of the conference.
Yeah.
Thank you.
Thank you.
Yeah, thank you all presenters. Thank you, Natalie, for moderating. Thank you to Monique for organizing the session. And let me just very quickly mention to everybody that up next is the State Showcase, Data Management and Quality and Public Accessibility. So I hope to see everybody there. Well, I can't really see any of you, but I hope you're there anyway. Have a nice day.